Afternoon, everyone. Another couple of minutes and we'll start.
जय जिनेन्द्र उमेश.
Hey, Jinendra, to you. How are you?
Fine, thank you. Thanks for inviting.
No problems at all. Right, I think we can make a start. It's 12:31. Okay. Make sure nobody else is waiting. Right, okay, I think we will make a start. Good afternoon to everyone. I hope you are all well. Whilst India battles through the second wave of coronavirus, in UK things are getting a lot better. In just under 12 hours, we will see the biggest ceasing of lockdown restrictions thus far. However, please take care and stay safe. Ladies and gentlemen, welcome to this week's Sunday Information Afternoon. This week, we have with us one of the top 25 women in psychiatry, Professor Nandini Chakraborty. Coming from a family of doctors in a middle-class Bengali background, her vocation was already chosen for her. Though Nandini ji wanted to be a geologist, before she knew she had entered Calcutta Medical School, and her single focus then remained to become a psychiatrist. She came to UK in 2003 and she held her first senior house officer job in Scotland. She is currently a consultant psychiatrist at Leicestershire Partnership NHS Trust. She is also an honorary professor at University of Leicester and an associate dean for Royal College of Psychiatrists. Nandini's journey in psychiatry continues in trying to understand people, cultures, and more importantly, how women stand in different societies. Her passion for nature continues in hiking, travel, travel writing, and solo female travel. In fact, for her 40th birthday present to herself, she climbed the Kilimanjaro. As part of Mental Health Awareness Week, ladies and gentlemen, please join me in welcoming Professor Nandini Chakraborty, who will be talking about understanding a diagnosis of psychosis, and schizophrenia. Nandini, over to you.
Good afternoon and namaste, everybody. Thank you, Umesh ji, for inviting me to this session. And it's a pleasure to connect with all of you and talk about a topic that I am really passionate about. I work as a general adult consultant psychiatrist in a specific team in Leicester called Early Intervention in Psychosis. So, psychosis is what I treat day in and day out, most particularly first episode of psychosis. That is my remit of expertise. And before I start sharing my slides, I want to give you a bit of context to what I want to convey to you. It is extremely encouraging to see that society today is becoming more and more aware of mental health and the need for mental health to be at par with physical health. With COVID and with all the things we have learned, there has also been an extreme amount of stress on people managing their mental health, about the impact on people's mental health through COVID. And within all that, I have taken encouragement. It has made me very happy as a psychiatrist. But in spite of all this awareness, psychosis and schizophrenia remain a relatively rarer set of mental illnesses which are still very misunderstood, and very little is known of them in a wider society. Sometimes, as professionals, when we are dealing with an illness day in and day out, we forget that not everybody has read or dealt with psychosis and schizophrenia. People understand depression, they understand stress, they understand anxiety, because these are problems that we have all dealt with at some part of our life. Coming up to one part of your life, I think all of us will understand what it means to be depressed for a day, what it means to be stressed at work, what it means to try and balance your work and your home life and your work life. We get that. But psychosis is rarer. Now, just to give an analogy, let's say we are talking about type 1 diabetes and type 2 diabetes. With type 2 diabetes, there is a clear link with maybe unhealthy life choices, with being overweight, with not taking enough exercise. And there is a family genetic link as well, which might be set off by unhealthy life choices. So for somebody to prevent type 2 diabetes, you can advise them that you've got this family history of diabetes, you've got to be careful, you've got to watch your diet, you've got to exercise. But when it comes to type 1 diabetes, that is linked more to a genetic load. It happens in young children. It happens without that link to lifestyle and being overweight. So it's this difference between type 1 diabetes and type 2 diabetes. If you understand, you probably will understand a bit more about the difference between somebody dealing with depression, anxiety, and somebody dealing with psychosis. With physical illness, yes, we have to develop healthy lifestyles, we've got to eat our fruit and veg, we've got to exercise regularly, but that is not going to prevent everything in a textbook of medicine. You will still have rare physical illnesses, you will still have genetic illnesses, and that is the thing about psychosis. Psychosis, of which schizophrenia is a particular type of serious psychosis, as a group of illnesses, are major mental illnesses. They have a genetic load, they have a chemical load. When we talk about the different factors which lead to mental illness and mental disorders, we are talking about biology, we are talking about psychology, we are talking about social and environmental factors. And within psychosis and schizophrenia, the biology is the predominant part. So that's the context that I want you to take away in understanding. But let me tell you a bit more about the specifics of what people experience in psychosis and schizophrenia. So I'll start sharing my slides now. Okay. So there we are. We want to understand psychosis and schizophrenia, and those are our learning outcomes. We want to explore what these labels are because you read so much about them in the media. You've probably seen films about them. You've probably, I'm sure you've definitely heard the words. And can we use some preventative measures, and how do we promote recovery? So psychosis, according to nhs.uk, is a mental health problem that causes people to perceive or interpret things differently around them, and they might have a set of symptoms called hallucinations or delusions. So psychosis is a wider rubric. Let's say we are talking about hepatitis. Now, hepatitis can be viral, bacterial, there might be other genetic causes for hepatitis, but there can be a particular kind of hepatitis which comes with, let's say, the hepatitis B virus. So psychosis is this general term. It's like hepatitis, but within that, schizophrenia is a particularly severe type. So it's a medical term indicating a break from reality. And it's not a diagnosis that we make lightly. When we talk about break of reality, we are not talking about people believing in conspiracy theories. We are not talking about people having a brief episode of drug intoxication. We are not talking about people who have acute stress disorder, have a huge trauma, and for 24 to 48 hours cannot think clearly. That's not psychosis. When we talk about a break from reality, we are talking about a severe disorder of interpreting the environment around us, which continues for a period of time. It doesn't come and go within that period. And it's a set of symptoms. What we do have in psychiatry is called syndromal diagnosis. So other than dementia, there aren't any CT scans or MRIs which will show up psychosis, but we want to understand what symptoms, what cluster of symptoms happen within these disorders. And it's those cluster of symptoms that we then look at treating in a particular way. We can give people a prognosis. We can give them a slight understanding of what to expect. When will the medications act? Can they come off medication? So that is what leads to a syndromal diagnosis, as we say. And so the word psychosis is to refer to an experience. It's a set of symptoms. And psychosis in itself is not a specific diagnosis. There are different types of psychosis that we deal with. Schizophrenia is one of them. It's common across all classes and cultures. So schizophrenia is not a Western world thing or a low and middle income country thing or an Oriental or South Asian thing. There have been studies specifically on schizophrenia done in the 1970s, 80s, and in early 2000, done by the WHO across all continents, across more than 10 countries, which show that these are real illnesses. Schizophrenia is a real illness with the same symptoms across all these countries and continents. That is what we are dealing with. We are dealing with a real illness, not just a cultural expression of distress. The content of what people experience might be different. For example, if somebody is experiencing a delusion in a Western society, they might say that there are cameras fixed in my room, or somebody is hacking into my Facebook page, or somebody's put me under surveillance. Somebody coming from a more rural area might have a simpler complexity to their psychosis, to their delusions, and they might simply think that people are talking about them, or people are following them around, or maybe somebody is doing witchcraft on them. Of course, that can also be a cultural belief, and it's very important that we distinguish what are cultural beliefs, religious, political, social beliefs versus delusions. But though the content of delusions and hallucinations can vary throughout the world, the form, the actual basis of the experience is pretty similar across all countries and cultures. Psychosis is usually a very young age onset illness. Most of our patients are in their early 20s. We get some people in their late teens. There are particular kinds of psychosis which can also develop in the 40s or 50s. So nobody's completely safe. We have no reason to be complacent. Gender prevalence across ages will level out, but in the younger age group, this is coming from our experience with locally in Leicester, at least we see within our team, at the younger age, we get more men. At a later age, in the 40s and 50s, the first episode presentation is mostly women. So what are the myths? Now, schizophrenia literally comes from a term which means split personality, but actually it's got nothing to do with split personality. Split personality is another rare illness, I've never come across it, which is a part of dissociative disorders. So let's not talk about that today. But schizophrenia, in spite of its literal meaning, has nothing to do with split personality. And also, I would say over here, I don't like the word schizophrenic. Nobody is schizophrenic. Schizophrenia doesn't change the person. People suffer from schizophrenia, and that is what society's got to understand with mental illness, that it's not about a person being unreasonable or difficult or deliberately making up things. You're talking about somebody who is suffering from a very real illness. People with schizophrenia need to be monitored at all times. No, that's a myth. People with schizophrenia can make full recoveries. 1 in 5 people, so that's round about 20% of people, will actually have an episode of schizophrenia and then come off medication completely and will not need treatment for the rest of their lives. 80 to 85%, however, will need medication, without which the relapse rates can be high. Within 3 years, 80 to 85% will relapse without medication. That's the statistics. But with medication, most of our patients have very good quality of life. They can be functional. And if you didn't know their background, there's nothing actually to show that they have once suffered from schizophrenia or psychosis. I remember having a medical student with me not a medical student, actually a work placement A-level student who intended to take up medicine and had shadowed me in my clinic one day. And we were talking to somebody who was really delusional at that point, very unwell. But this person was, neatly dressed, sitting in the chair, had actually, come by 2 buses to the clinic that day to see me, and could sit in the chair and very calmly talk about his delusions. And the student goes, "Goodness, he looks completely normal." And I thought, goodness, what did you expect? Are you basing your opinions on movies where people are shown in asylums behaving really, really funny? And that's not mental illness. People can be seriously unwell, but they don't come across as our stereotype of mad or crazy. And so people with schizophrenia can have perfectly normal lives if they are treated early, if they are treated properly, and if they continue to take their medication when it's indicated and appropriate. People with schizophrenia are dangerous. No. The problem is that the media focuses on sensational stories. It's always the story of somebody with paranoid schizophrenia who has murdered the next door neighbor with a machete. And I wish we had more positive stories. I wish we had more people coming out telling people of their success stories. The problem is, due to stigma, the people who have made their lives battling the illness, taking their medication, still continuing to do well, are afraid to come out and say, "You know what, I've got a diagnosis of schizophrenia," because people will look at them a different way. And so you don't get to see the success story. But believe me, I've been in this team for 11 years. There are loads of people we have discharged back to their GP on a stable dose of medication who go on to do their university courses, complete their PhDs, work regularly, have normal lives, families. They just don't disclose their diagnosis to anybody. other media misconceptions, as I was talking about. The media never tells us the positive stories, or maybe people are afraid to come to the media to share their positive stories. So all the time we get the stories are when things go really, really wrong. Let's talk a bit more about schizophrenia, because that is the more particular illness, which is the most severe. And that is the kind of psychosis which continues for a longer period of time, according to the WHO criteria, more than 4 weeks, which sounds very, very short, I must say. According to the American system of classification, more than 6 months with multiple psychotic symptoms are needed for a diagnosis of schizophrenia. It's a long-term illness. It is a lifelong diagnosis, but people can be managed with medication. They do get better with medication. Again, it's like somebody having a diagnosis of asthma or diabetes. You will have the diagnosis for the rest of your life, but you will have good patches and bad patches. You might need more medication at some time, less at other times. And it's a combination of taking medication and lifestyle that helps you maintain a good quality of life. So the lifetime prevalence, according to nhs.uk and the NICE website, is approximately 14.5 per thousand people, though these can be considerably variable in different regions. So that is schizophrenia, a number of psychotic symptoms for a prolonged period of time. And the symptoms start very differently in different people. Sometimes people can have a more acute onset. Until last week, they were doing well, and then suddenly over a week, they have become unwell. Something might just spark it off at one point of time. There are others who develop schizophrenia very insidiously. So when you look back, maybe over 6 months, a year, they have been having low threshold depression, anxiety, not functioning, concentrations falling, something that if you see at that point, you'd probably think it was depression or anxiety, but it doesn't seem to respond to any medication, any treatment. And then gradually at one point, they start developing psychotic symptoms. And the symptoms are probably the most difficult for people to understand if you have not dealt with psychosis at close quarters. Just to share some experiences from families, it's very difficult for a mother, let's say, to suddenly face a young son, let's say 20, 25 years old, was studying, maybe working, lots of friends, everything going normal. And then suddenly one morning, son comes up to her and says, I'm not going to eat your food because you're poisoning me. Or goes up to the father and says, you're not my dad, you're an imposter. You've kidnapped and put my father away in a cell and you've taken his place. And people are bewildered because they've never heard about delusions, they've never heard about psychosis, or at least just heard the term psychosis, but don't know what it entails. And these symptoms, this behavior is, I can understand, is absolutely bewildering. Why is your child behaving with you like that? Or when it comes to the older age group, where we see that more complex delusions predominate, suddenly a son seeing the mom who has been a reasonable, strong, well-functioning woman for all these years, suddenly starting to believe that there are unmarked police cars following her and there are cameras in the room and the neighbors are talking about her, and the children trying to reassure their mom that, mom, nothing's happening. You know, why are you saying these things? But we have to realize that for somebody going through psychosis, these are very, very real symptoms. And I'll talk a bit more later about why they experience this symptom, what exactly is going on in the brain for them to feel that the world has suddenly changed around them. It's very difficult for families to understand how to react. If you agree with them because you don't want an altercation, people think that, goodness, am I entrenching their beliefs? Am I encouraging them to become more unwell? And yet, if you contradict them and say, look, you're being unreasonable, nobody believes you, nobody agrees with you, the person can get more agitated. and might think that their family are in league with the persecutors. So the best way to deal with it is the middle way, to say that, look, we've got to agree to disagree. I understand that that this is very real for you, but sorry, I'm not experiencing the same thing. This is your experience, and we've got to stop over there. Now, schizophrenia can have two sets of symptoms. The positive symptoms are these symptoms, the hallucinations or delusions. So they are not positive in that sense, but they are the addition of experiences which are not normal, which we don't want to have. Whereas negative symptoms are the loss of function. So over the chronic period of illness, people start losing motivation, they stop socializing, they don't have the way, the drive to prioritize, to plan. Something seems to go out of them like a switch. The difference with depression is that they don't see this as a problem. They will make excuses like, I'm just chilling, I'm just taking my time, I am deciding. They'll probably try and convince their families that, no, I'm sitting in front of the laptop and I'm looking for jobs. I just haven't found anything. Or they might be just going to university, but not doing anything over there. And when drug and alcohol problems, which are very commonly associated, not with everybody, but it's a very common comorbidity, when that comes into the picture, it is really, really difficult to distinguish how much of it is drug and alcohol and how much of it are negative symptoms. Also, we've got to accept that antipsychotic medication with which we treat schizophrenia can also cause tiredness and sedation. And we try and give medication which is much newer nowadays with less side effects. Definitely, there have been advances made in that way. But in the chronic course of illness, it is the side effects of medication, the negative symptoms, and problems with drugs and alcohol, which can make things pretty clouded. So what are hallucinations? Hallucinations are the perception of senses when there is nothing really around us. So when people hear, see, smell, taste, feel a touch, when there is nothing there, that is when we say that they are hallucinating. And hallucinations can happen, let's say, when people are intoxicated. There are instances of people having very brief hallucinations when they are falling asleep or when they are waking up. People can have hallucinations if they are within solitary confinement, for example. But the hallucinations which happen in psychosis are predominantly hearing voices which are not there, voices or sounds. So these are what we call auditory hallucinations. And the reason why they are happening is because it is the hearing area of the brain, the temporal area of the brain, as we call it, which gets chemically sparked off, creating the sensation of sound when there is really no sound wave hitting our ears. In a way, what we see around the world, what we see as happening around us, is what our brain tells us is happening. So when our sense organ picks up sensations, those travel through the nerves, they hit our brain, the brain then sparks off on certain receptors, and that is when we feel the sensation, whether it's hearing or smelling or tasting. But consider the chemistry where these brain receptors, the sense receptors, are getting sparked off without real sensations flowing in. The experience for the person would still be exactly like if a sensation had flowed through a nerve. So that is what creates a hallucination. People are not making it up. It's very real for them. If they hear the neighbor speaking next door, or if they hear people outside the door talking, it is exactly like as if people are really talking over there. They are not imagining it. They are not making it up, and no amount of reassuring them will actually help, until at one point they start to understand that, goodness, I am hearing voices when people are not around, and then some of them gain insight into it. but for most of them, they might create other delusions or other beliefs that, oh, there was somebody around in the door. They just ran away when I opened the door. Or people are managing to project voices through electromagnetic waves, or I'm hearing this because somebody's inserted a microchip inside me, and that's why only I hear it and nobody else hears it. Our brain is always trying to rationalize experience, and that is how the delusions and the psychosis develop. There is one psychotic experience, very frightening for the person, but then the person tries to make sense of it, but they keep on adding other layers, other delusions, other psychotic experiences until they are within this world of theirs, which is completely detached from reality. And this is what I was talking about delusions, a belief held with complete conviction, which is difficult to shake, impossible to shake, and it is not explained by the person's religious, social, political, cultural background. So you and I can come from very different cultures. We can share very different beliefs, but that's not to say that we are going to label each other with a delusion. Right now, COVID conspiracies are floating around in so many places, but anybody who believes in a COVID conspiracy is not delusional because they are part of a social system which might believe in that particular explanation of what's happening as a group. But when people have this very individual experience and they have a belief of something happening where they are absolutely at the center of it, whatever's happening is happening very unique to them, that is what we label as a delusion. There can be other very complex delusions that which are very unique to the person that we don't have time to talk about today. But hopefully, if you come across anybody who is describing a very delusional world, you will probably understand them and empathize with them a bit more after this talk, I would hope. And people can have confused thoughts and a thought disorder, as we call it, and how that is expressed by a very jumbled conversation. So this is not like the conversation in, let's say, somebody with dementia. Here you get a sense that you understand every individual sentence, you understand every individual phrase, but somehow at the end of 5 minutes, if somebody asks you to say, oh, what was that person saying? You find it very difficult to explain because it's got so lost within the individual sentences and phrases. It doesn't make overall sense. It's all very complicated. People with schizophrenia can also show changes in behavior and thoughts. They become more disorganized, unpredictable. Some of their behavior we can associate with hallucinations or delusions. For example, somebody laughing to themselves or talking to themselves might be responding to hallucinations. But there are more other behaviors which are not directly associated with hallucinations or delusions, but are odd by themselves. For example, people can have catatonic posturing, or they can sometimes experience their thoughts being physically taken out of their head, or somebody inserting thoughts into their head, which is a very intrusive, a very frightening symptom for somebody to go through, because your head space is so private. That is one area where you know that you have complete control over, and to feel that somebody's taken over that headspace, or to feel that you're being driven by a robot. Often people will also describe being manipulated physically like a robot or like a puppet. They have no control over what is happening to them. And these are all symptoms that they describe in the course of schizophrenia and psychosis. Negative symptoms we've already talked about. This slide gives you a bit more of detail, but just to say that negative symptoms are very low-key because you don't have somebody who's agitated or aggressive, but these are the symptoms which affect long-term functioning. The sad thing is that they are often missed because they are not, let's say, creating trouble for other people. They are not seen as a risk to themselves or others. but then they seem to become chronic over years, not attaining their potential, becoming very dependent on others, being exploited along the way. And unless we treat schizophrenia early, negative symptoms come along the way. And that is why early intervention services are set up. The team that I work in, a first episode psychosis team, has this very specific aim of diagnosing and treating schizophrenia early so that we prevent negative symptoms happening in the first place. Once negative symptoms come in, they are very difficult to treat and they don't always respond to medication. There are other psychotic conditions as well. So people can have delusional disorder, which is just having lots of delusions, very complex, very related to each other, but no hallucinations, no other psychotic symptoms. This is what we see more in the older age group, in the 40s, 50s, with a female preponderance. We can have organic psychosis, which might happen, let's say, in the context of a brain tumor or some kind of brain inflammation. We can have psychotic depression. So people who get severely depressed or severely manic in the course of bipolar disorder can have added psychotic symptoms to the mood disorder. People can have drug-induced psychosis. So other than intoxication, there are certain drugs and certain people who can spark off a longer psychotic episode. People can have stress-induced psychotic episodes, which we call acute and transient psychotic episodes or reaction psychosis. And all of these psychotic disorders will have different courses, different prognosis, as we call them. And when we take off medication or we try and manage without medication depends on the individual and the diagnosis. These are some quotes for people who have been through psychosis or schizophrenia and at a time when they are probably more insightful and understand that they are they have been delusional, because when they are delusional, they will never accept that they are delusional. They won't describe themselves as being paranoid. They will say that this is really happening. I am not being paranoid. I am not being delusional. People can also have quite bizarre memories, so of things which never happened. I had a patient who once told me that he had a twin brother who was taken away from him when he was 6 months old. But the family said that he never had a twin brother. Or another patient who says that, I remember being a monk in Tibet. He had never visited Tibet in his life, but the memory was there, full formed, very vivid in his brain. And these are all quotes which fit in with the symptoms that I've been trying to describe so far. So coming to the diagnosis, this is a diagnosis which can be suspected by a GP, but when it's suspected, a GP will always refer to a psychiatrist, probably a first episode psychosis team. And the diagnosis would involve the psychiatrist then talking to the patient, talking to the family. Sometimes the diagnosis is clear at the first assessment when people have years of history behind them. Sometimes it takes a longer time. Sometimes diagnoses do change along the way. For example, people might have had a very acute episode, less than 4 weeks. It all got better in hospital. We think, okay, this is acute and transient psychosis. But then you take off the medication, the person relapses, it starts going on for longer, and then you realize that you're dealing with schizophrenia. Or people might develop a mood disorder, and along the way they might develop other psychotic symptoms. So you understand that maybe they have something between schizophrenia and bipolar, which we call schizoaffective disorder. Or sometimes an episode might appear drug-induced, but then as time goes by, we realize that no, the person does have a primary psychosis like schizophrenia, or they might have bipolar disorder. It wasn't caused by the drugs, but it was unlocked by it. So they will need more long-term treatment than just keeping off illicit drugs. So there aren't investigations. There isn't a blood test. There isn't a brain image. If we suspect that, okay, is this organic? Is this something to do with a physical illness? Then we might do tests to rule out physical illness, but there isn't a diagnosis which will, and a brain image or a blood test that will confirm psychosis or schizophrenia at the moment. Yes, psychiatrists will use specific questions focused on psychotic symptoms. They will talk about how the symptoms developed, when they developed, what came before, which symptom. And these are the two classificatory systems that we use. I was talking about in the US, it's called the DSM, the Diagnostic and Statistical Manual of Mental Disorder, whereas the WHO use ICD-10, and within our trust, the official classificatory system is ICD-10. And then talking about recovery, because I've told you about something which is serious and absolutely, has to be taken, is not to be taken lightly. But I also want to give you that story of hope that if we do treat people at the right time, in the right way, and if people work with us without denying the diagnosis, without going on head on that, no, this is trauma induced, this is stress induced, we can get on just with, helping this person have a healthy lifestyle and, with a lot of family support and love, and they will recover. That's not the case. When we talk about recovery, yes, we are not talking just about symptom resolution. We want our people to have, our patients to have a quality of life. We want them to go back to work. We want them to go back to their studies, to reestablish relationships, to have families. That is what we are aiming towards. And that is the story of recovery. I don't want to give my patient such a high dose of medication that they will become zombies. It might be that they still have some residual voices going on, but we have a balance of medication which might not control the symptoms, but at least it doesn't give them horrible side effects and they can still function. So recovery is not about getting all the symptoms out of the way. It is about getting people to get back their quality of life and function. And within that journey of recovery, we've got to talk about medication and we've got to talk about lifestyle. Yes, I don't say that all my patients have a background of drug and alcohol disorder and chaotic families, not at all. But when somebody is suffering from psychosis, having illicit drugs in the background is not going to help. So, good lifestyle is not going to cure all your illnesses, physical or mental, but it can at least reduce the dose of medication that you need. It can make the outcome better. It can even make your medication more effective. So if I am giving somebody antipsychotic medication, and they're taking cannabis at the same time, I might need to give a higher dose of medication to try and counteract the psychotogenic effects of cannabis. I would definitely not minimize the impact of having a good lifestyle, work-life balance, good sleep, mindfulness exercises, social contact and exercise. But if people need antipsychotic medication, they need it, and there is no denying it. Psychological treatments can also help. They can, again, add on to the effects of medication. CBT is the most common thing that we use, but there is also a part for family therapy, because often psychosis can impact on family dynamics hugely. When people especially develop delusions against their family, there can be a lot of fracturing within the family itself. And even when the person has got better, the family might need help to re-establish those links. I know it's easier said than done when we tell a relative or a loved one that, I know, the patient has said horrible things about you, but it's nothing personal, that they weren't themselves, they weren't thinking right when they said that. It's very easy for professionals like me to say that. It's not that easy for a family member to forget if it has continued for a long period of time, and if there has been any physical violence involved as well. It can be very frightening. We do work with our patients to identify warning signs and triggers, and these warning signs and triggers can be very individual, very specific for the patient. Some people might start with very slight irritability, others might start with losing sleep. There are others who might start feeling a bit disorganized at work. And if we catch these early symptoms, if they are having an episode later on, then we can prevent things from getting too bad, too floridly unwell, at least in the second episode, even if we haven't prevented it in the first episode. The first episode often comes to us, to our notice, when people are really unwell, and no disrespect to the patient or their family, people don't understand psychosis. They try and manage things themselves at home, whether it's because of the stigma or the lack of understanding. And that is what we want to get out there in terms of a message, to understand what might be psychosis and bring it to the notice of services earlier rather than later. These are some of the pointers within the NICE guidelines for schizophrenia and psychosis, and everything has its place. There is CBT, there is medication, there is family intervention, art therapies. These are two links that I will leave with you in the slides. They are, beautiful short videos to look at, especially the first one link about from Mind. This shows 4 people with schizophrenia doing well on medication, now talking to each other about their experiences, and it's a really, really good video, very realistic, gives you the message of, I think, cautious optimism. It doesn't minimize schizophrenia, but it also shows you a positive story. And that is the journey that we are trying to look at. We want that recovery approach, not just give people meds and get rid of your voices. We want to make sure they come back to their normal lives. And these are some useful contacts I will leave you with to think about or read about more if you are interested. But that is the end of my slide deck. So I will come back into the room now. Thank you all very much.
Nandini ji, that was excellent. Thank you so much. And we've got quite a number of questions, if I may ask. Um, so the first question I have is depression part of psychosis?
Now,
And
sorry, go on, Umesh.
is depression part of psychosis? And a follow-on is, can people with the condition get agitated at seeing certain people with whom they would have behaved normally before?
Right. So depression and psychosis are two different things. Might be related in a way, as I said, when people get severely depressed, they might have added psychotic symptoms. And these are what we call mood congruent psychotic symptoms. So somebody with severe depression might hear voices telling them to kill themselves, or telling them they are a bad person or worthless person. They might develop delusions that they are bankrupt, or some catastrophe is going to happen to them or their family, or that they are dying from cancer, when that is not true. So a psychosis can be secondary to severe depression, but they are not the same. And we wouldn't call depression a psychotic symptom as such. And sometimes people with it might develop the psychotic symptoms first, and they can have depressive symptoms later. For example, if I believe that my family is against me and that my family are poisoning me, of course I'm going to feel low about it. So people can have depressive symptoms over there. But no, it's depression is not a psychotic symptom. That's the simple message over there, though they can coexist, let us say. And the second question about agitation, yes, absolutely. And think about it again, being in their shoes, right? So I developed a delusion that my next door neighbors are not actually next door neighbors. They are MI5 agents keeping an eye on me, right? And I'm absolutely fixed about this. And I also start believing that they are actually making a plot to kill me. And I start avoiding them. Now, if I meet them on the streets, of course I'm going to be agitated. These are people who are plotting to kill me. These are people who are intruding my privacy and have put cameras in my room. If you consider that scenario to be real to you, of course you're going to get agitated. So, so a person who behaved well with, with neighbors, friends, etc., if they develop delusions against them, are obviously going to get agitated and not going to listen to reassurance about it, to be honest.
Thank you. Okay, I've got the next question. Can depression be recovered, and psychosis be recovered by religious activities, prayers, chanting, meditation, rather than taking medication, which would have a side effect?
Um, no is the simple answer. If people have serious mental illness, they need the treatment for it. Yes, religious activities which give us a cultural bonding are soothing, they are supportive, and as an adjunct, I would never discourage them. But to place reliance that alone will help recovery without antipsychotic medication, absolutely not. I mean, again, going back to the description of type 1 and type 2 diabetes. In type 1 diabetes, you've got to give insulin. Yes, a healthy lifestyle might reduce the dose of insulin. It might make the management of the illness better, but you're never going to treat type 1 diabetes without insulin. So, psychosis and schizophrenia is like that. About depression, now depression, if we are talking about people having normal reactive depression, which is in proportion to their circumstances. So if somebody's lost a job or is going through bereavement, realistically, they are going to feel low for a couple of days and couple of weeks. So in that case, if they are religious people, if they find some activity soothing, that itself might be supportive enough to help them get through. But when that crosses over into what we call clinical depression, and clinical depression is a chemical illness, like schizophrenia, it does have a chemical background to it, and people feel extremely guilty that they are feeling low like this when their circumstances don't warrant it. Many people will tell you that, I can't make sense of, I've got a loving family, I've got a job, I've got all resources. Why do I feel this way? And yet in the morning they get up, they are low, they're feeling low, they don't feel energy, they don't feel motivation. Clinical depression will need CBT and medication. So, only family support or religious support is not going to help.
Thank you. What are the current timescales of getting a diagnosis?
Okay. Now, within early intervention in psychosis, we have to see a patient and make a decision within, from referral to that decision time has to be 2 weeks. That's one of our key performance indicators within services. However, things can be different depending on individual circumstances because, as I said, presentations can be quite complex, and very subtle onset of psychosis might not even be detected or realized by the family and patient for maybe a couple of months or couple of years even. And by the time they come to us, they might have had an illness for 1 or 2 years. But from referral from GP or crisis team or from an inpatient admission up to early intervention teams, our criteria is 2 weeks at the moment.
Okay, thank you. What help is there for the families? So apart from the patient, what help is there for the family to cope with the whole situation?
Again, it's coming back to what my team provides, and so within Leicestershire, I can talk about the family support over there. But actually, there are early intervention teams across the country We work with these colleagues, especially when we have people living between two areas, university students living in one area and studying in another. So, there are early intervention teams across the country who work on very similar guidelines that we do. So within our team, we have a carer support group or a carer psychoeducation group that runs several times a year for 6 sessions. That's something that very particular that we provide in Leicester. But their loved one, the patient has to be under our care at that point. It's not for people who are who've been discharged from us or who are not under the Leicestershire team. Within our team, we also provide family therapy, as I said, behavioral family therapy, which is a pair of therapists, usually our care coordinators or nurses with supervision from a psychologist or psychotherapist, who go in and give very specific therapy to the family depending on their circumstances. Other than that, let's say within the Leicester Partnership Trust itself, we have a recovery college, and the recovery college around the year runs lots of courses. So these are one-time psychoeducation sessions, kind of like what I'm doing today. I will share with you that my slides are the same slides that I use with Recovery College. I had presented this very thing in with a bit more of detail on Friday. And that group includes patients, carers, professionals. It's a mixed group that we deliver to. And in a wider scale out there, outside mental health services, you could get in touch with organizations like Mind, for example, and they could guide you to, what is available for families. So it's a bit heterogeneous around the UK, but that's to give you some idea.
Okay, thank you. A question here: would an early intervention team see someone who is reporting first incidents of psychosis at the age of 89?
No, no. We, in fact, were limited between ages of 14 and 35 until 2016. So, and the biological reason for this is that most first episode psychosis biologically appears in that young age. But in 2016, we opened the doors to people to up to 65 years of age. So basically, we are general adult psychiatrists and general adult professionals. So that's our age group, working age adults. We work with CAMS for people between 14 to 18. Then we take over their care if needed at that point, if there is first episode psychosis. And then our caseload is 18 to 65 at the moment. But somebody with first episode of psychosis above 65 will get referred to their catchment area old age psychiatry team.
Thank you. Another question I have, Nandini, is it true that that sensitive people are more prone to depression and psychosis?
It's about how you define sensitive. That's a very that's a very subjective term in my opinion. And when it comes to clinical illness, I will say no. In 11 years, I have been absolutely surprised at how many people I've seen and that is more the bewilderment of the family, that these people until 6 months ago were high functioning, resilient, took a lot of work-life stress, function normally. And once you treat their psychosis, they go back exactly to that kind of lifestyle. So it's definitely not a feature of somebody who was less resilient or sensitive or somebody who could not manage stress. If people cannot manage stress, yes, it makes it more difficult for future, but not all psychosis or clinical depression comes from pre-existing personality traits, let us say. And I'm more and more aware, as I say, as a half joke, of my own vulnerability. Up till the age of, even until we were taking a caseload up till ages of 35, I used to think in my mind that, I'm very close to 50. So I used to think, I am well and safe out of, first episode psychosis. But then when we opened the gates to above 35s, and then, as I said, in that older age group, we are getting more and more women. And some of these women have, they are fascinating. What they have dealt with throughout their lives, what they have managed. You sometimes wonder, is there an effect of cumulative stress? And I think maybe, that's the research that we need to have. That is the, very simply speaking, is the male brain more susceptible to acute stress, whereas in females, does it build up over years? And that's why we get them more at a late age, but they definitely don't come across as sensitive or vulnerable or less resilient to me. Not at all.
Okay, thank you. So there's somebody who knows someone diagnosed with with psychosis, bipolar with psychosis. They are on medication, but can they be weaned off it slowly as they show signs of improvement? And would that have any effects on whether the symptoms would return?
It's very, very individual. I have seen people with a diagnosis of bipolar come off medication and remain well. And I have seen people come off and relapse. And the unpredictability with bipolar is you do not know when the relapse will happen. So we've got to be very practical and patient tailored in order to take them off medication if that is what we decide. So let's say, for example, somebody has episodes once every year and they appear like clockwork. And we can see that, every April, let's say they have an episode. We know that come April, they've got to be prepared for it. And before they become floridly manic, they have a week when they start losing sleep, but they're still otherwise thinking and functioning normally. So you have a window to intervene. So if that person wants to come off medication and just use it intermittently during the time of the episode, you can see that that will work. But there are people who become very acutely unwell, and every time they become unwell, they end up in hospital. It's a huge trauma for them. It's a huge trauma for the family. It's an absolute disruption in their life, that one day they are okay, the next day they're floridly gone manic and psychotic at the same time. And maybe these episodes are happening every 6 months. And for them, you've got to think, no, practically taking you off medication is not going to work. It's going to be too disruptive. And there is the balance about whether the medications are giving them side effects. If a tiny dose of medication can prevent relapses for future and is not giving them side effects, you've got to practically think, is the risk of relapse worth by taking them off medication? So, these are very individual questions.
Okay. I've got another question. Sorry, I think it's 1:30. I've got two or three more questions, if it's okay with you.
Yeah,
Okay.
absolutely.
So the next question I have is, how do the spheres of psychosis and dementia overlap, if at all?
And people with dementia can present with delusions and hallucinations, and obviously it is an organic change in the brain. But the treatment will not be the same as you would treat with schizophrenia. I would admit, hand on heart, that I'm not an old age psychiatrist. So an old age psychiatrist would probably would obviously be more knowledgeable in informing you about how psychotic symptoms within dementia will be treated. There is a difference, however, between how you would see delusions in schizophrenia versus delusions in dementia. There is a difference in that thinking process. So somebody with schizophrenia might come home and they see something slightly changed in position. And immediately they start thinking that or believing that somebody's been inside the house. There's no signs of intrusion, so somebody's got a duplicate into my room. Somebody's keeping, but nothing's missing, so they are actually just spying on me. This is a conspiracy, etc. People go on changing locks of their house over and over again, but they still believe that that is going on. Whereas think about somebody with dementia. Obviously, the main feature of dementia is memory loss, it's forgetting. So they might actually put something somewhere and actually forget due to the dementia, and then believe that somebody's stolen it. So the thought process, you can see, is different. So when people with dementia are accusing others of having done things, about, especially about taking their things or misplacing things, I wouldn't very technically call that a delusion, but I would see that as a result of their forgetfulness and memory loss.
Okay. Next question I have is, within psychosis, how do we classify someone who is perfectly normal? However, unexpectedly, they display severe bouts of anger issues, throwing things around. People do not feel safe to be near them.
Yeah. If this is all the information that you're giving me as a psychiatrist, that, there's no delusions, there's no hallucinations, this person simply gets angry and throws things around, I'll take a bit more of history to pin down what's happening. It might be simply somebody with anger issues.
Hmm.
And it depends on whether these episodes of aggression have always been there. Is this somebody with anger being a problem as part of their personality, that the moment things don't go their way, if they get frustrated, that is how they express themselves, then that aggression is not necessarily a part of psychosis. That could be just an anger issue. But again, if somebody who was usually very calm, soft-spoken, otherwise, really, easy to get on with, and suddenly out of the blue, one day they've become angry and aggressive, then yes, I'd start looking deeper into what's happening over here. But just with anger and aggression, it could be anything. It could be them developing a mood disorder. People within depression can get irritable and angry. People with mania can get irritable or angry. People might have had one-off a spliff of cannabis or an illicit drug and shown that spurt of anger and aggression. So yeah, but just based on one episode of anger and aggression, or if that is the only feature, I would dig deeper for a specific diagnosis.
We'll take one more question, and I think that we will then have to. There's quite. It's a very. It was a very informative session, and I think it's one area that doesn't often. It isn't spoken about, and people kind of resist talking about this area. So there are a lot of questions, but I'll take one more question, and I'll ask you one more question. What is the difference between bipolar and borderline personality disorder, and
Okay.
how can you support someone with either of this?
Okay. So first of all, with any diagnoses can coexist. So the first thing I'd like to say is that it's not like somebody with bipolar cannot have borderline personality disorder, or borderline personality disorder can't develop, bipolar. But it's like that psychosis, schizophrenia, schizophrenia, depression question that we were talking about, that these are two very different diagnoses. So with borderline personality disorder, or any personality disorder for that fact, is something developmental and is part of the person themselves. That is their baseline. So the usual history we have is that of a disturbed childhood and somebody having difficulties with their relationships from an early age, and a diagnosis you make into adulthood when personalities are developed, or when they have this emptiness within them. Borderline personality disorder is basically characterized by that emptiness. They don't know where they stand in this world, what their identity is, what they want out of life. And if you are an average person with that motivation, that drive, there's something that wakes you up in the morning and you want to do this, if you have dreams and aspirations, it's very difficult for us to understand and empathize with somebody with borderline personality disorder who's missing that. We take these features for granted. That yes, I am going to dream about having a good job and going on holidays and having a family, etc. But and you have you form an identity where you fit in, in terms of which community you're part of or which professional group you're part of. But somebody with borderline doesn't know where to fit in. And that leads to this lifelong presentation of impulsive behavior, because they're always switching and changing their minds. They have mood swings, but the difference with the bipolar mood swings is that it can happen on a day-to-day basis. So they wake up in the morning feeling great, by evening they're suddenly feeling low, or they are feeling low, something happens, and then suddenly they are feeling manic and they go and spend a lot of money. So you see that switches on a day-to-day basis. Whereas in bipolar disorder, you're talking about an illness which is superimposed on somebody with usually a normal personality. So this person will have it, and it's an episodic illness. So between the episodes, the person is completely normal. Intermittently, they are working, functioning, interacting. The episodes change their interaction with people significantly when they are feeling manic or depressed. Whereas with borderline personality disorder, that is how they chronically interact with people, how they manage stress, how they cope with things in a maladaptive way is part of their life story from beginning to end. So that's the difference between borderline and bipolar.
Okay, thank you. There are a couple of other questions, but I think we have to call it a day at this point. Nandini ji, thank you so much. Really, really appreciate you coming and talking about this subject. It's a subject where I certainly have learned a lot more about in the last 45 minutes. I know it's a subject that still isn't talked about a lot over the last since the lockdown. I think people are accepting depression. They are talking a lot more about depression. They are talking a lot more about mental illness, but something like psychosis, schizophrenia, it's very, I think people don't open up, and I think there's a very negative connotation to the words, and I think that's what is holding people talking about it. But I think you've given a fairly good understanding to our listeners, our viewers, and I just hope that there are more talks like this where people that there is more knowledge being shared with the public. uh, Thank you so much. Really do appreciate it on behalf of everyone. Thank you.
Thank you. Namaste, everybody.
Namaste. By the way, the presentation will be on my YouTube channel and that will be shared with everybody. Thank you. Bye.